If I told you that 1 in 10,000 young women will actually go through menopause before they even turn 20, you'd probably assume I was, just confusing my medical terms.
Right, yeah. People hear menopause and immediately think, well, that's for your 50s.
Exactly. I mean, that is the
Yeah.
biological itinerary we are all handed, right? The
Yeah.
expected chronological calendar we base our whole lives around.
We rely really heavily on that schedule. I mean, the expectation that your reproductive system operates on this, predetermined 50-year timer, it's deeply ingrained in how we view health and aging in general.
But today, we are looking at a stack of medical data that completely shatters that timeline. We're pulling from these comprehensive clinical frameworks. So guidelines from the NHS, NIWITE, the Royal College of Obstetricians and Gynecologists, and the British Menopause Society to really decode a very specific systemic endocrine disruption.
Yeah, it's a deep dive into some really critical terminology.
Right. Our mission today is to answer a surprisingly complex question, which is what exactly is early menopause and how is it defined clinically?
It is such a critical distinction to make because in casual conversation, you hear the words early and premature just sort of tossed around interchangeably. Like they mean the exact same thing.
Yeah, absolutely.
But medically, they represent very distinct metabolic states, and they have drastically different long-term health implications. So when you look at the clinical consensus, treating them as the same thing is, well, it's a dangerous oversimplification.
Okay, so to understand what early actually means, we first have to establish the baseline. What is the standard biological timeline we are measuring against here?
Right, so natural menopause is medically defined as the permanent cessation of menstruation, and that's driven by the loss of ovarian follicles. It's the definitive end of reproductive potential.
Got it.
And in the UK and Canada, the average age for this transition is 51, with the standard physiological window falling anywhere between 45 and 55.
And from a diagnostic perspective, it's not really an event you can just pinpoint on a calendar the day it happens, right? Like you don't take a test on a Tuesday and get a positive result for menopause.
No, not at all. It is diagnosed entirely retrospectively. The clinical marker for a natural menopause transition is 12 consecutive months without a menstrual period, provided there is no other, underlying physiological or pharmacological cause for the period stopping.
So you only officially reach the milestone a full year after your ovaries have ceased regular function.
Exactly. You're looking backward to make the diagnosis.
Okay, so 51 is the average, and 45 to 55 is the standard deviation. If that's the baseline, where do we draw the line for early?
So the clinical definition for early menopause applies specifically when this permanent cessation occurs between the ages of 40 and 44.
Wow, okay.
Statistically, we are looking at about 5 in 100 women. So roughly 5% of the population will experience this shift before they turn 45.
And then we cross another boundary line.
Yeah.
Because if 40 to 44 is classified as early, what happens when the timeline shifts even further forward? Like before 40?
Yeah, when it happens before the age of 40, the medical classification changes entirely. The updated terminology is Premature Ovarian Insufficiency, or POI.
POI.
And the data here just completely upends our normal associations. POI affects 1 in 100 women under the age of 40. It affects 1 in 1,000 women under 30. And like you mentioned at the start, it impacts 1 in 10,000 young women under the age of 20.
That is just, it's mind-blowing. I was thinking about it like a train schedule, right? So early menopause is like arriving at the final station a bit ahead of schedule, getting there at 42 instead of 51. You took the normal route, just at a slightly accelerated pace.
Right, exactly.
But premature menopause, POI, that is the train skipping major stops entirely. You are arriving decades before the destination was even in sight.
That's a great way to put it. Skipping those developmental and biological stops changes the entire physiological trajectory of the patient. The body is suddenly deprived of decades of hormonal support it was expecting to have.
Which brings up the obvious physiological question. I mean, if the train skips 5 stops and terminates in a 25-year-old's body, what threw the switch? What actually triggers early menopause or POI?
Well, often it is idiopathic, which basically means it happens naturally and we simply never find a definitive trigger.
It just happens.
Yeah, though genetic predisposition plays a really significant role. If a primary relative experienced it, the statistical likelihood goes way up. We also see chromosomal variations like Turner syndrome acting as a catalyst. But one of the more fascinating natural disruptions is autoimmune disease.
Okay, wait, I want to push back on a common assumption here, because this autoimmune aspect really changes how we think about this. I think the default assumption is that, A woman is born with a set number of eggs, and POI just means she went through her reserves faster,
Yeah.
like a clock winding down at double speed.
That is what people assume, yeah.
But what you're saying is that in many cases, it's actually an external factor, like an autoimmune response, actively destroying the process.
That is a vital distinction to make. It isn't always a simple depletion of reserves. In an autoimmune response, the body's immune system fundamentally misidentifies the developing follicles in the ovaries as a foreign threat.
Wow. So it attacks them.
Exactly. It generates antibodies that actively attack and shut down ovarian tissue. So it is destruction, not just depletion.
That's incredible. I'm also looking at the data on lifestyle factors here in the guidelines. Things like smoking or being severely underweight are listed as risk factors. How does simply lacking body fat actually shut down an entire reproductive system early?
So adipose tissue, which is body fat, is actually an active part of the endocrine system. It produces a weak form of estrogen called estrone. If a patient is severely underweight, they lack that secondary estrogen buffer.
Oh, I see.
Combine that with the fact that severe caloric restriction can signal the brain to shut down non-essential functions, like reproduction, just to conserve energy, and you accelerate the timeline. As for smoking, the toxins directly damage the ovarian follicles, accelerating their natural death.
But beyond genetics and lifestyle, it seems a massive portion of these cases are medically induced.
Yes. Medically or surgically induced menopause is a completely different clinical landscape. This is the result of treatments for conditions like cancer, so chemotherapy, or pelvic radiotherapy, which are highly toxic to the ovaries. Or it happens through a bilateral oophorectomy, which is the surgical removal of both ovaries.
And the physical experience of a surgical menopause has to be vastly different from a natural transition, right?
Oh, the clinical data explicitly notes how severe the contrast is. In a natural or even an early natural menopause, the decline in estrogen production is gradual. The ovaries kind of sputter. The body has a buffer period to try and adjust to the shifting hormone levels.
It eases into it.
Right. But if you surgically remove the ovaries or you obliterate their function with chemotherapy, you eliminate that buffer completely. The estrogen drop-off isn't a slope. It is an absolute cliff. The onset of symptoms is abrupt, and they are typically far more aggressive.
Okay, so the ovaries shut down, either gradually or suddenly. What is the immediate biological fallout? Because, estrogen is not just a reproductive hormone. It's a systemic hormone that impacts almost every major organ.
Yeah, the most immediate clinical marker is a change in the menstrual cycle, leading to periods stopping entirely before 45. But the cascade of symptoms that follows is driven by that systemic estrogen deficiency. The most well-known are the vasomotor symptoms.
Right. We hear about hot flushes and night sweats all the time, but biologically, what is actually misfiring? Why does a lack of estrogen make someone randomly drench their sheets in sweat?
It comes down to the hypothalamus, which is the area of the brain that acts as the body's internal thermostat. Estrogen helps regulate the hypothalamus. When estrogen levels plummet, that thermostat becomes wildly hypersensitive.
Like a broken AC unit.
Basically, yeah. The brain mistakenly detects that the core body temperature is dangerously high, even when it isn't. So to prevent overheating, it triggers a massive physiological cooling response. Blood vessels rapidly dilate to release heat, which is the flush, and the sweat glands just go into absolute overdrive.
It's essentially the body hitting a false fire alarm.
A false alarm that leaves patients completely exhausted, constantly interrupting their sleep architecture. But the fallout goes much deeper. You see urogenital atrophy.
Right.
Estrogen maintains the elasticity and thickness of tissues in the pelvic region. Without it, those tissues thin and shrink, leading to severe vaginal dryness, pain, and a really high susceptibility to recurring urinary tract infections.
And the data also points to musculoskeletal issues, like unexplained joint stiffness and muscle pain. And we definitely cannot ignore the psychological impact. Low mood, profound anxiety, brain fog, and real difficulties with memory and concentration.
It's a massive systemic shock.
But here is where the clinical guidelines from NICE get very specific, and honestly, a bit confusing at first glance. How the medical community officially diagnoses this depends entirely on the patient's age.
Yes, the protocol is rigidly stratified by age. For an otherwise healthy individual over the age of 45, the diagnostic criteria requires zero laboratory testing. A physician will diagnose menopause based entirely on a clinical assessment of their symptoms and the cessation of their menstrual cycle.
Now, if you're listening to this, you might be wondering why a 46-year-old gets a symptom check. But a 38-year-old presenting with the exact same hot flushes and missed periods has to undergo multiple rounds of specific blood work. Why the intense rigorousness for the under 40 crowd?
Because of the massive long-term health implications of diagnosing POI, the clinical threshold for proof is just much higher. Under the age of 40, you cannot diagnose based on symptoms alone. The guidelines mandate evidence of elevated FSH, follicle-stimulating hormone.
Let's explain the mechanics of FSH. How does testing a brain hormone tell us what the ovaries are doing?
It's a classic biological feedback loop. The pituitary gland in the brain constantly monitors estrogen levels. When levels are low, the pituitary pumps out FSH. It is literally the brain shouting at the ovaries to stimulate a follicle and produce estrogen.
Okay, so if the ovaries are functioning,
They respond, estrogen goes up, and the brain stops shouting. But in POI, the ovaries do not respond, so the brain just keeps shouting louder and louder. High levels of FSH in the blood indicate that the ovaries have stopped listening.
right, but the protocol requires 2 separate blood tests, taken 4 to 6 weeks apart. Why the delay? Why not just test it once?
Because in younger individuals, ovarian function can fluctuate wildly. The ovaries might shut down and then intermittently sputter back to life. A patient might have a temporary return of their periods, and crucially, they still carry a small risk of spontaneous pregnancy.
Oh, wow.
Yeah. So by mandating 2 elevated FSH readings over a month apart, clinicians are verifying that the ovarian shutdown is a sustained physiological state, not just a temporary anomaly.
Right. Confirming this total shutdown with multiple blood tests isn't just about labeling a frustrating set of symptoms. It's about managing the biological reality of a body that was expecting decades more estrogen. Which brings us to the long game. What is the actual documented risk of spending an extra 10 or 20 years in an estrogen-deficient state?
When we evaluate the long-term data, the primary metric of concern is the sheer duration of the deficiency. If the biological blueprint expects a transition at 51 and a patient goes through POI at 35, they are enduring 16 additional years without estrogen's protective mechanisms.
And what exactly is estrogen protecting during that time?
The 2 most critical systems impacted are skeletal and cardiovascular. Let's look at bone health first. Bones are not static, dead structures. They are constantly remodeling themselves. You have cells called osteoclasts that break down old bone and cells called osteoblasts that build new bone.
Okay.
Estrogen is the hormone that restrains the osteoclasts. It keeps the demolition crew in check.
So when the estrogen drops off entirely?
The demolition outpaces the construction. The bones rapidly lose density, leading to osteoporosis. And the clinical data shows this doesn't just mean a higher risk of breaking an arm or a leg in a fall. The bones in the spine can literally microfracture and collapse under the body's own weight, causing chronic pain and a loss of height.
That's terrifying. And the cardiovascular data is just as stark. The clinical review highlights a massive study of over 22,000 women. It demonstrated that early natural menopause, so occurring between 40 and 45, is associated with a 40% increased risk of heart failure compared to individuals who transition at the average age of 50 to 54.
A 40% statistical increase is profound. Estrogen plays a vital role in maintaining the endothelial function, which is the inner lining of the blood vessels. It keeps them pliable and healthy. Without it, arterial stiffness increases.
Wow.
And this risk is even more pronounced in patients who underwent bilateral oophorectomies. Surgical removal of the ovaries generates a sharper spike in cardiovascular disease risk than early natural menopause.
I really want to synthesize this because the implications are huge. Think of estrogen as the structural scaffolding and the insulation of a complex building.
Right.
It is holding the walls up and keeping the pipes from freezing. If you remove that scaffolding 15 years ahead of schedule, the infrastructure, your bone density and your vascular elasticity is going to take on accelerated wear and tear. You lose your structural integrity far sooner than biology intended.
That analogy gets right to the core of the issue. We aren't just talking about managing the discomfort of night sweats here. We're talking about preventing premature structural collapse. Furthermore, for a patient in their 20s or 30s, the immediate psychological trauma of losing their fertility just cannot be overstated. The guidelines are adamant that managing POI requires comprehensive, holistic care.
Right. So if the biological scaffolding is suddenly gone, how does modern medicine artificially maintain the building? How do clinicians rebalance the scales for a patient facing decades of deficiency?
The gold standard, the primary intervention recommended across all these major clinical frameworks, is hormone replacement therapy, or HRT. Alternatively, a combined hormonal contraceptive can be used. But the critical directive from NICE concerns the duration of the therapy.
Okay.
The mandate is that hormone replacement should be continued at least until the age of natural menopause.
So until age 51. You aren't just taking a pill to make the hot flushes go away. You are strategically replacing the exact hormones the body should have been producing organically.
Precisely. You are artificially maintaining the bone and heart protection for those missing years. This is the standard of care unless there is a rigid contraindication, such as, a patient with a history of estrogen receptor-positive breast cancer.
I have to ask about the safety profile here, because if you are listening to this, you have likely seen the media headlines. There is an enormous amount of public anxiety surrounding HRT. If a 32-year-old is diagnosed with POI and the clinical guidance is to take exogenous hormones for 2 uninterrupted decades, are they inherently destroying their heart to save their bones?
It is a totally rational fear, honestly, based on years of poorly communicated science. But the current clinical consensus is definitive. HRT does not increase cardiovascular risk when initiated under the age of 60.
Oh, wow. Okay.
Yeah, in fact, for a patient with POI, it is actively protecting the heart. Even in patients who have optimally managed cardiovascular risk factors like controlled hypertension, HRT is not contraindicated. You are not flooding the system with dangerous excess. You are simply filling the tank back up to the biological baseline.
That makes perfect sense when you reframe it as a baseline replacement rather than some sort of enhancement.
Yeah.
But the specific method of replacing those hormones matters immensely, right? The guidelines get very specific about patches versus pills.
Yes, the delivery mechanism fundamentally alters the risk profile. The clinical recommendation points heavily toward transdermal HRT, which means delivering the hormone through the skin via patches like Everol or gels like Ostrogel.
Okay.
This is especially critical for patients with a higher background risk of venous thromboembolism or blood clots, which includes anyone with a BMI over 30.
What is the biological difference between rubbing a gel on your arm and swallowing a pill? Why does the pill increase clot risk?
It comes down to an anatomical detour called the first pass effect. When you swallow an oral HRT pill, it goes into your stomach and is absorbed into the portal vein, which carries it directly to the liver before it hits the rest of the body.
Right.
The liver metabolizes that massive hit of estrogen, and in the process of breaking it down, the liver ramps up the production of coagulation factors, which are the proteins that make your blood clot.
So the liver's reaction to the oral estrogen is what spikes the blood clot risk.
Yes. Transdermal HRT completely bypasses the liver's first-pass metabolism. The hormone is absorbed through the skin directly into the systemic bloodstream, delivering a steady dose without triggering the liver to flood the body with clotting factors.
That is so interesting. Now, for symptoms that systemic HRT might not fully resolve, the guidelines point to targeted therapies. Vaginal estrogen can be applied locally, long-term, to reverse the thinning tissues and alleviate urogenital pain.
And for the severe psychological distress and low mood, cognitive behavioral therapy is heavily recommended. But what's equally important is what the guidelines advise against. Clinicians are explicitly warned not to routinely prescribe SSRI or SNRI antidepressants as a first-line treatment for vasomotor symptoms.
Which means treating the root endocrine failure, not just masking the neurological symptoms.
Exactly. You have to rebuild the scaffolding, not just paint over the cracks.
This entirely reframes how we need to think about this diagnosis. So to pull all these clinical threads together for you, early menopause, occurring under 45, and premature ovarian insufficiency, occurring under 40, are not just instances of the biologic clock running a bit fast. They are distinct systemic endocrine disruptions.
They really are.
They require rigorous diagnosis, often tracking those FSH feedback loops and active decades-long management with hormone replacement to preserve the structural integrity of the skeleton and the cardiovascular system until the natural baseline age of 51.
Treating a 35-year-old with POI the exact same way you treat a natural 51-year-old transition ignores the massive physiological deficit they are facing. Whether you are navigating this yourself or you are supporting a friend or family member, understanding that distinction is the key to preserving long-term health.
It really is. And it leaves us with a final thought to mull over. Our culture almost exclusively weaponizes the concept of menopause as a synonym for aging. It's treated as the punchline to getting older.
Yeah, constantly.
But when an autoimmune response or a chemotherapy regimen triggers menopause in a 25-year-old or a 40-year-old, it completely shatters that association. How might our cultural conversations and, critically, our workplace policies and healthcare frameworks need to adapt if we stopped treating menopause solely as a symptom of a ticking clock and started viewing it as a systemic hormone transition that can occur at almost any stage of adult life?
Decoupling the biology from the age stigma changes the entire paradigm of patient care.
Keep asking those questions. Thank you for joining us on this deep dive. Keep looking past the assumptions and keep diving deep.